شكرا. بس if you can switch off the light علشان يوضح أكثر. Good morning, colleagues. My name is Dr. Ebtihal Al-Jaman. I'm a consultant in internal medicine and KBIM site coordinator and a clinical biochemistry clinical tutor in your program. Thanks, Dr. Dana and Dr. Jumana, sorry, Dr. Jumana and Dr. Salwa for inviting me to give this talk. Basically, this talk is derived from the textbook that you are reading, guys. So I just went over it. It's kind of a review, but the biochemical aspect, I left it to the people of their specialties. So we're gonna start by going over the objectives. By the end of this presentation, inshallah, you will be able to describe the bone metabolism, understand the mineral, and list the biochemical measurement of bone disease, and describe the bone mineral homeostasis, and describe the hormonal regulation on mineral metabolism, and understand the clinical aspect of different metabolic bone disease. Kind of a refreshment. I know all the doctors, they don't like the basic sciences, but believe me, you need it in your life. This is a great foundation for you guys to proceed in your career, whether you are in clinical aspect or laboratory aspect. So basically, the bone cell types, we have 4 of them. The precursor is the osteogenic cells that will differentiate into the osteoblast, which is responsible for the bone formation. And this later on, it will differentiate into the osteocyte that is responsible for laying down the minerals, basically the phosphorus and the calcium. There is a counter-regulatory cell, as I call it, the osteoclast, which is responsible for bone destruction. Early in life, we have the pre-osteoblast that is responsible, that is the precursor for the osteocyte. It passes through different stages of maturation. The first one, it will grow and it will start to lay down more collagen, but the activator proteins will decrease in this phase. Then it will differentiate into an osteoblast, which is the bone-forming cell. And at that time, the markers inside this cell will increase, like the alkaline phosphatase. Then it will proceed to the pre-osteocyte, where it enters the mineralization phase, and it starts to differentiate into the osteocyte, laying down the phosphorus, the calcium, and the other minerals. And then it will end up by cell death and apoptosis. About up to 30% of our skeletal bone get remodeled yearly. And the influencer for that are the vitamin D, calcium, and phosphorus with the PTH. And also there is a hormonal aspect that influence this remodeling, like the estrogen will prevent the bone resorption, while the cortisol and the PTH will stimulate the bone resorption. And the growth factors like insulin growth factor, this will promote the bone formation. Let's go over the remodeling cycle of the bone. In your textbook is described into 5 phases, but just like in a clinical aspect, as you know, we describe it in 6 phases. It starts with a trigger. The trigger could be a micro damage or stress to the bone itself. This will lead to the activation of the osteoclast. I will just like, if there is a mouse here, oh, it's here. Okay. This will cause the activation of this osteoclast precursor cell. This will trigger the phase of the osteoclastic activity. Where's the arrow? I lost it again. Okay. There we go. This will trigger the osteoclastic activity, where this cell will break down the bones and it will end up later on in apoptosis. And we call this a reversal because now we are getting ready for the reversed process, which is the activation of the osteoblast. A growth factor gets released from the bone that will stimulate the stem cells to differentiate into osteoblast, the dark blue cells. And this is responsible for making the bone again. After that, it will differentiate into osteocyte, that will lay down the minerals and end the stage of mineralization. Then we'll go for a resting phase or quiescence. To summarize this, we're gonna start with the activation. Before the activation, there is a trigger, which is micro damage or mechanical stress. This will lead to the osteoclast precursor to get activated. This is in the activation first phase. Then it will go to the resorption where it's gonna function and break down the bone. After breaking down the bone, the cell will die. So we'll go to the reversal, we'll get ready to the reversal phase where the cell is getting ready to develop into the osteoblast, that is the bone formation. After that, we'll reach a state of equilibrium. We have a nice bone with full of osteocyte as in the termination, and we'll stay at this phase for a long time until another stress happens again. We'll go through the cycle. So stress or a damage followed by activation, resorption, reversal, formation, termination, and then quiet phase. I hope this is clear for everybody. What happened in childhood life and adolescent, the bone formation will be very high. This is marked at the first graph. There is a bone growth. So we have a lot of bone formation in comparison to the bone resorption. This will stay until the early 30s of age. And then we're going to enter the other phase, that is the remodeling. In adulthood, we're going to lose bone rather than making more bone. So, what are the essential bone minerals? Basically, they are the calcium, phosphorus, magnesium, fluoride, and manganese. But we're going to talk about the first three minerals. The estrogen is very important in terms of bone remodeling. Why it is important? Because the estrogen will have an inhibitory effect on the TFGB, that is the marker, that is the transmitter will cause the apoptosis of the osteoclast cell. So we will not have much of osteoclast that's going to destroy our bone because of the estrogen. The other thing, it will inhibit the cytokines that will activate the osteoclastic activity. That's going to destruct our bone. In premenopause, the estradiol, the precursor of the estrogen, and the inhibins are really elevated. So the bone will have osteoplastic activity, more bone formation. In postmenopause, we're gonna lose the effect of the estrogen, and the estradiol and the estrogen will decrease, also the inhibin, and this will activate the osteoclastic activity. There is a variation in the bone loss between male and female, being higher in the female because of the physiological process, just like the pregnancy and lactation. This will affect your calcium reserve and the bone mass. So we are basically the same with the male in terms of the bone losses until we plateau in both gender between the age of the after the 25 till the mid 40s. Then we will have just like a sharper drop in the bone mass because of loss of estrogen effect. Calcium is an intracellular and extracellular cations. Okay, most of it, just like most of it, 40% of it is attached to the protein, and 10% is complex with other ions like the citrate, the bicarb, and the free calcium or the ionized calcium or the physiological calcium will contribute to 50% of the 60%, which is ultra filterable. What do you mean by ultra filterable? It's gonna pass the semi-membrane of the cell because of it is a smaller size. But the protein-bound calcium is affected by the pH mainly because this will affect the bonding between the protein and the calcium itself. And the ultrafiltrable calcium is affected by the hormones like the BTH and the vitamin like vitamin D. I will explain this further in this slide. Most of your bone, you find it in the teeth, and most of your calcium, you find it in the teeth and the bone, up to 99%. Only 1%, which is available in the blood. Among the 1%, 50 of it, this is the physiologically free or ionized calcium that is involved in the metabolism, and this is the measurable part in the lab. 10% of that is bound to other complexes like the citrate, phosphorus, and the bicarb. 40% of it is bind to the protein. So any change in the protein, any change in the pH will affect your ionized calcium concentration in the blood. If you have a low pH, like in a state of acidosis, you're gonna have a lot of a free or ionized calcium. The vice versa in the alkalosis, you will have a decreased free calcium in a state of alkalosis. If you have too much protein, you're gonna have there will be increased calcium. If there is a decreased protein, there will be a decreased calcium as well. This is look like a complicated equation. Describe the effect of the pH on the ionized or physiologically active calcium. So just ignore it and concentrate on the last line. For each 0.1% change in the pH, there will be an inverse change in the amount of the concentration of the free calcium by zero point zero 0.05 millimole per liter. To wrap up the calcium thing, we're going to talk about the homeostasis. If you have a state of hypocalcemia, this is going to trigger the parathyroid gland, and the parathyroid gland will secrete the PTH. The PTH will have a direct effect on the kidney that will increase the calcium resorption, and it will act directly on the bone by releasing the calcium from the bone by the effect of the osteoclast cells. It will have indirect effect on the vitamin D. It helps it to go into the active form that will act on the gut to absorb the calcium and phosphorus, and on the bone to release the calcium. If we're going to compare between the extracellular and the intracellular calcium, we're going to compare, first of all, about the abundancy. As I told you, most of your calcium is in your bone and in your teeth. Only the 1% that is physiologically active that govern your body. Among this, we will have an extracellular calcium in two forms, either free in the vessel or it is compound to a protein. Inside the cell, we will have a little amount of a free calcium, and some of the calcium will be bound to the sacroplasmic reticulum that exists in the cells, in the muscles, cardiac, skeletal, and the smooth muscle, and this will help in the contraction of the muscle. And the free calcium will help us also in the synapses of the neuron, and this will have a great effect in the transmission of the signals through the nerves and the neuron cells. So what is the role of the intracellular calcium and the extracellular calcium? As we said, the intracellular calcium exists either free in the cell itself or attached to the sacroplasmic reticulum in the skeletal cell. So it will lead to a muscle contraction, cell division, glycogen metabolism, and hormone secretion. What about the extracellular calcium? This is like a backup for the intracellular calcium to reach a state of equilibrium and homeostasis. It is very important for the bone mineralization, and also it has an effect on the blood coagulation. How is that? The calcium is required to get the prothrombin into the thrombin phase. So this will help to lay down the fibrin and cause blood coagulation, and also it is important for the membrane potential. If you have a low calcium, just to go over it again, This will trigger the release of the PTH, which will act directly on the bone to release the calcium, directly on the kidney to reabsorb the calcium, indirectly on the gut through vitamin D to increase the absorption. If you have too much calcium, the parathyroid hormone will have no role into that. The follicular cell in the thyroid will release the calcitonin. The calcitonin will push the calcium back to the bone and it will excrete the calcium through the kidney. What kind of effect you will see if you have a state of hypocalcemia clinically? So this is will cause an excitation state, and this will manifest as involuntary contraction. So the patient will come with a tetany, or if you tap on physical examination over the parotid to stimulate the seventh cranial nerve, he will end up by having a twitching, and we call this Jovistic sign. Or if you inflate the PP apparatus over the arm, the patient will have a carbopedal spasm, okay? And this is, we call this Trojer sign. The other thing, patient may have a muscular cramp. Most of us from time to time will end up by having a muscular cramps, especially during sleep. This is related to the state of hypocalcemia and hypomagnesemia. And they may end up by having a tingling and numbness around the mouth. So what are the causes of hypocalcemia? Our approach to the etiology of hypocalcemia will be either PTH related or vitamin D related or non-related to both. So the PTH related, we're going to talk about a state of decrease in the PTH that is characterized by hypoparathyroidism, either because of post-radiation, post-operative, or sometimes without any reason. Or you have an intact PTH molecule circulating in your blood but not exerting the effect. This is a PTH resistant, either because you have a genetic abnormality in your receptors like in pseudohypoparathyroidism, or you have an increased concentration of the counter-regulatory hormone, the calcitonin, that will counterize the effect of the PTH. When we come to vitamin D, okay, we'll make it as simple as this. Either you are not taking enough vitamin D, so you have a deficiency, or you are not exposed to the sun enough, so you'll end up in deficiency, or you have, or suppose you are don't have any deficiency in vitamin D, but you have a problem with your gut because of malabsorption, either post-operative, okay, or you have just like other states that will affect the vitamin D absorption in your gut, or you have a resistance to the vitamin D itself. You don't have the correct receptor for the vitamin D to attach and exert its effect, or you have an end organ damage like renal failure. So your kidney will fail to produce the active form of vitamin D, or your liver failed to produce the active form of vitamin D. The other thing you can think about infection like HIV or inflammation that will lead to the precipitation of calcium like in pancreatitis, fat metabolism, and rhabdomyolysis, or massive blood transfusion because the blood will have a citrate, and this is a chelating agent for the calcium. It will take it away from your system. Or you have electrolyte disturbances in terms of hypomagnesemia or hypophosphatemia that will affect your calcium homeostasis. And of course, the sepsis, because sepsis is marked by inflammation and release of cytokines that can affect the calcium homeostasis. How do you treat that? We have a short-term treatment and a long-term treatment. It depends on the presentation of the patient. If you have to correct it within minutes to hour, you have to give an IV calcium in a form of 10% calcium gluconate. If you have to correct it over days or weeks, then you have to replace it with vitamin D. To decide which analog of vitamin D to use, you have to look at the PTH. Do you have a PTH deficient? If you do have a PTH deficiency, then go straight away to the active form of vitamin D. So you are bypassing the liver stage, the kidney stage, you are giving the end product. So it is ready to exert its effect at the targeted site. If your PTH is intact, then you can have the vitamin D2, okay, analog, either the 1 hydroxylation or 125 hydroxylation, and you give it on certain frequency. The hypercalcemia, our approach to it, we will look the same as the approach of hypocalcemia. Is it BTH related or non-BTH related? If it is BTH related, it means I have a state of hyperparathyroidism that will excrete a lot of BTH that will act on the bone and release the calcium. It will act on the kidney and reabsorb the calcium, and I will end up by having a state of hyperkalemia. Or you have a familial hypocalciuric hypercalcemia, or you have an extra source of PTH excretion. The non-PTH related, is it related to vitamin D? The person is taking a lot of vitamin D, or he has an excess of calcitriol. This is one form of the vitamin D, okay? Or this is non-vitamin D related. The body is excreting protein-like PTH. We call this PTH-like protein as a consequence of a tumor, or we have a lot of calcitriol secreting tumor, or we have a bony metastasis from different organs. As I said, the physiological active calcium, this is the free calcium, and this is the one that we measure in the lab. Most of the calcium is in the bone and in the teeth. We have a certain amount of calcium, which is the 40% of the 1% is in a free form, and the other is attached to albumin or attached to other chelating agent. If you look at the cylinder, the first cylinder, which is labeled as normal, we have an equilibrium state between the calcium concentration among the three phases. You have the calcium, you have the albumin attached to 4 molecules of calcium in the pink, and the orange one, we have, what is the arrow? And the orange one, we have the chelating agent, the chelating agent, okay, where the calcium is attached to the bicarb, and then the blue one, this is the free calcium. What about if I have a less protein? So I'm gonna have a shrinkage in the compartment of the albumin bound calcium. This will adversely affect the concentration of my free calcium. But wait a second, my free calcium is not really affected with that. So this is why I have to correct it. And the corrected formula is you get the measured calcium, add it to 0.2% times the end product of 40 minus albumin. Like in this example, if your calculated calcium is 1.25, after correction for the low albumin, it will elevate to 1.65. The pH will affect your calcium bounding to the albumin. In a state of acidosis, the albumin will has a less affinity for the ionized calcium or the free calcium. This will lead to a state of increased free calcium. In alkalosis, the affinity of albumin will increase. It will attach more calcium. So your ionized calcium or your free calcium will drop. If you look at the curve, the ionized calcium, there is an inverse relationship between the concentration of the ionized calcium and the pH. Remember from the previous slide, any change in the pH by zero point 0.1 will be faced by an inverse change in the free calcium by 0.05. But the relationship between the protein bound calcium and the pH, it's a direct. If the pH increase, your a protein bond calcium will increase. Always remember the figure. If you have a high pH, like in alkalosis, the albumin will has high affinity for the calcium. So it's gonna attach more calcium. Then your bound calcium will increase. So there is a direct relation between the protein bound and the change in the pH, but indirect relation between the free calcium and the pH. تفضلي. Okay, look at this diagram. If you have albumin attached to the calcium, okay, like in the normal state, if you have less amount of albumin, there will be less binding between the albumin and the calcium. This will falsely drop your if your measured free calcium, but you have to correct that. The correction is through this formula. The measured calcium plus 0.202 times 40 minus the albumin, because you will have less albumin attached to the calcium. This will give you a false free calcium. Is that clear, doctor? The free calcium falsely low. So we have to correct it to the given amount of albumin. Okay? What about the effect of heparin on the calcium? Heparin is one of chelator for the calcium. Okay, like the adita, which is present in the testing tube, it will combine to the calcium and it will lower the calcium in vivo. As I said, the calcium is important. It will trigger the formation of fibrin through accelerating the prothrombin through thrombin and fibrinogen to fibrin. So the heparin will have a chelating effect on the calcium and it will lower the calcium in vivo. There is a physiological variation in the concentration of calcium in the body. This will depend on the physiological state, whether the patient is pregnant or not, sleeping or active, the age, the gender, and the season. Let's look at the physiological state. If you look at the bar graph, okay, this is the amount or the concentration of calcium in the plasma in different trimester of a pregnancy, being the highest in the first, okay, then tend to lower in the second and the third, if you compare it with the non-pregnant female. During sleep, you will have less calcium in your body and less phosphorus. If you wake up, because of the effect of the sun, you will have more calcium. This is through the vitamin D. And the other thing, don't forget the PTH effect on calcium. The PTH will follow the biological clock of the body, and it follows your activity as well. The one that we use for interpretation of the calcium is the free calcium or the physiological calcium or the ionized calcium. This is the one that we measured, and this is controlled by the PTH, vitamin D, and the calcitonin. The urinary calcium, this is controlled or affected by the excretion of the calcium, and this you can measure it in the urine, and this is can be increased by the thiazide and the PTH. This will stimulate the excretion of the calcium through the kidney. Then we're going to talk about the phosphorus. The phosphorus, basically, this is similar. I will call it the close friend of the calcium. It has three phases. Most of it is free, okay, or it is complex, 35% complex with other chelating agent in the body, or 15% is compound to the protein. We have two forms of the phosphorus, either organic or inorganic. The inorganic one, this is you find it mainly in your skeleton, okay, and you find it also in the extracellular and intracellular body fluid. The organic, you find it in the soft tissue and in the nucleus. The phosphorus, if you look at the diagram here, okay, the phosphorus basically the same like the calcium. You ingest the diet, it will get absorbed from your intestine, then it is involved in the activation of the BTH and also the vitamin D. But there is a diurnal variation, as I said. The phosphorus will be less during the sleep, that is at night. Okay, it will be more during the daytime. There is another guy get released from the bone. We call this FBGF or we call it FGF2. This is the fibroblast growth factor 23. This is get released from the bone. It will help to get ready from the extra phosphorus inside your body through the kidney. So if you have a state of hyperphosphatemia, it will trigger the bone to release the FGF223 to excrete the phosphorus through it, okay? And also this, the drop in the phosphate will have an inhibitory effect over the parathyroid hormone. And the FG will inhibit also the parathyroid hormone release. I will explain this with this slide. So if you have a state of hypophosphatemia, you want to know what are the causes of this hypophosphatemia. Think about the gut. Either you are not taking enough, or you have a problem with the absorption, that a lack of vitamin D, okay, or you have a state of imbalance between the extracellular and intracellular. In a state of acidosis, you will have what's going to happen to your phosphate? Your phosphate will increase, and it will increase. In a state of alkalosis, like in hyperventilation or metabolic alkalosis, your phosphate will drop and will give you a state of hypophosphatemia. If you have a problem at the level of the kidney, like in Fanconi syndrome, where your kidney will start to excrete more phosphorus, okay, then you're gonna end up by having this also state of hyperphosphatemia. Or if you have abnormal elevated excretion of FGF223, this will cause a state of hypophosphatemia through too much excretion of phosphate through the kidney. Hyperphosphatemia, this is the mirror image or the reverse of the hypophosphatemia. If you want to approach it, think about it in this way. Am I talking about the cellular level? Do I have a problem with the kidney? Do I have a problem with with the absorption of this phosphate? Or do I have a pseudo hyperphosphatemia? That means an extra source of phosphate. So, in the terms of the cellular level, you may have a state of acidosis, either metabolic or respiratorily. You have a state of insulin deficiency. This is what happens in DKA. Most of our patients, they will come with a state of hyperphosphatemia because they are lacking insulin, and there is more abundant phosphorus in the blood than the usual. Or you have a problem with the kidney itself that will lead to a decrease in the excretion of the phosphorus, like in advanced kidney failure or CKD. And you may have a state of hypoparathyroidism. You don't have much of the parathyroid hormone to facilitate the excretion of your phosphorus through the kidney. If you go to the gut, you have a problem with absorption of the phosphorus. You have too much absorption of phosphorus. This could be because of vitamin D toxicity. If you come to the pseudo hyperphosphatemia, which is mean that this is not true, you may have a state of tumor lysis, where the tumor itself, this is the source of the increase of phosphorus in the body, or the hemolysis, where the blood cells get burst and release the phosphorus, or any state of other hematological malignancy like the multiple myeloma. How do we treat that? The concept behind the treatment, we want to prevent the absorption of phosphorus. Okay, look at the fuchsia circles. This represents the phosphorus, and the binders are the purple, the double circles. So we want to stop that. We want to stop the vicious cycle that's going on between the PTH, the phosphorus, vitamin D, and the calcium. So we give a chelating agent like calcium citrate. This will bind to the phosphorus and get it excreted through the feces. The third mineral is the magnesium. Most of the magnesium you will find it in the muscles and the soft tissue and the bones, okay, and a little bit in the soft tissue. The free is again the free magnesium in the blood is around 1%, and the magnesium is very important at the cellular level because this is a cofactor and enzyme helper for metabolic reaction in our cell at the level of the cytoplasm, at the level of the nucleic acid. When you think about the magnesium homeostasis, think about the bone, nerve, and muscle. So the magnesium is important cofactor, okay, for a tons of enzyme. As I said, at the nucleic acid level, at the nucleus level, like in DNA repair, DNA synthesis, okay, and certain metabolism inside the cell, like the glucose, lipid, and the protein metabolism that happens in the cytoplasm. And also, it's a source of energy. It is involved in the ATP production, and also it can give a structural support for the muscle and for the skeleton. And also, this is the second messenger that is involved in, um, and that is involved at the cellular level. And also, this is the ions that is antagonize the calcium effect. So, if you think about the magnesium, think about the muscle, think about the bone, and think about the nerve as a neurotransmitter. What are the causes of hypomagnesemia? Either you are losing it through the kidney, like in certain congenital deformities, Pater and Gettleman, or you have an increased loss, intestinal loss, okay? The intestinal loss because you have just like a surgical, now in the era of the bariatric surgery, there is a surgical and anatomical alteration of the gut that may lead to the absorption of the deficiencies of these minerals, or you don't have enough intake of that, or you have a state of disequilibrium between the intracellular and the extracellular, or the person himself is taking excessive chelating agent, as I call them, like alcohol, and they're gonna end up passing them in the urine. Hypomagnesemia adversely affect your bones through a direct effect and indirect effect. Let's look at the indirect effect. It's going to decrease the abundancy of the parathyroid hormone and hence the vitamin D. So you're going to end up by having altered bone formation. And also it will exert an oxidative stress and a state of inflammation on the bone on the bone, so this will increase the osteoclastic activity and bone resorption. Uh, in addition, it's gonna cause endothelial damage, and this will affect the blood supply. The direct effect, it will cause it will affect the cell of the bone by increasing the activity of the osteoclast and decreasing the activity of the osteoblast. And also, it's gonna cause a state of crystallization, and this will make your bone stiff but brittle. and the patient will end up by having a stage of osteoporosis. This is why most of the patient with the Glitterman or Battler syndrome, they will manifest an early age osteoporosis because of the hypomagnesemia. What are the causes of hypermagnesemia? Either you are taking too much magnesium, like the anti-acid, okay, or you are taking, whether it's intravenous or orally, or you have a tumor lysis syndrome or renal failure. The effect of hypermagnesemia, we're going to concentrate mainly on the muscle. It's going to cause a state of muscular weakness, okay, loss of tendon, reflexes, and it will cause a state of paralysis. The CNS is going to cause a headache, dizziness, convulsion, and GI is going to cause nausea and vomiting. And in terms of the muscle function, it will affect the smooth muscle, mostly of the bladder, by causing urinary retention through abnormal contraction of this muscle. And it can cause arrhythmias if it affects the heart. What is the regulator of the bone metabolism? From the previous slide, you figured out the parathyroid hormone, vitamin D, they are a great regulator for the calcium by acting at different level, including the gut, the bone, and the kidneys. If you look at the PTH is secreted from the parathyroid hormone in response to elevation of phosphorus and drop in the calcium. So if you have a state of hyperphosphatemia, okay, this will cause the bone to excrete the FGF23 that will take the calcium and put it back in the bone, and also it will go to the kidney and ask it to excrete the excess phosphorus. Also, the parathyroid hormone, this will have an inhibitory effect on the parathyroid hormone, which means there will be no increased absorption, there will be a reduction in absorption of the calcium and the phosphorus through the gut, and they will accelerate the increase, the excretion of the phosphorus. The active form of vitamin D is controlling many or the bone metabolism through different level. First of all, it will act at the parathyroid hormone, okay, and this will decrease the secretion of the PTH, so no more calcium will come out from the bone, okay, and also it will prevent the further absorption of calcium and the phosphorus, and it will increase the excretion of calcium. It will increase the reabsorption of calcium through the kidney. Though the vitamin D will act on the kidney, bone, thyroid, and the gut. This slide basically summarizes what we said. The most important thing is the state of hyperphosphatemia that will lead to the release of FG23, which will have a direct effect on the kidney by excreting the phosphorus through the urine, and it will have an inhibitory effect. This is the red dotted line on the parathyroid hormone, so it will stop the parathyroid gland from secreting the PTH, and also it will stop the conversion of vitamin D3 into the active form by decreasing the absorption of the calcium and the phosphorus. So the biological action of the PTH, it will act on the bone, as we said, intestine, and the kidney. To summarize it, if you the vitamin D, we get that we get the start from the sun. It will activate the cholesterol in the skin, will give the precursor to the liver. It will get hydroxylated in a place of a 25. Then It will pass it over to the kidney to get further hydroxylated at place number one, and it will go through the thing that you really know. And the parathyroid hormone that controls also the metabolism and the homeostasis of the vitamin D3 and the calcium through the bone and the small intestine. We have a different variant of vitamin D3 and want you to pay just like a number, pay attention to the number because this is really important in terms of our decision of a treatment um, in clinical cases. So the D3, this is the so we have D3 and D2. Okay, the precursor for the vitamin D, as you know, this is the cholesterol, which is found in this under the skin that get activated through the sunlight exposure. It will give you the pre-D3. Okay, so this is the precursor for the active form. And then through the gut, you can eat also from the dairy product the precursor, the D3 and vitamin D3 and vitamin D2. All these forms are not hydroxylated. The hydroxylation takes place, first of all, in the liver at the space of 25, and finally in the kidney at the space of 1. So the active form is the 125. This is the active form, and 24, 25, this is just like, the pre-active, we call it. And if you have a patient with an intact BTH, you can give them vitamin D3 and vitamin D2. This is the available in the multivitamin tablets over the counter and without a prescription, provided your BTH is normal. If you are BTH deficient, you will skip the hydroxylation and give the final product. That is 125 or 25 hydroxylated vitamin D3. This is basically the same. This is a regulation. Let's talk about the metabolic bone disorder. As we said, in childhood, adolescent, the bone formation is more than the bone resorption. We're gonna reach a plateau between the age of 20, early 20s to mid 40s, and after that, the bone resorption or remodeling will happen. And it will get accelerated post menopause in the female because of the loss of estrogen protective effect. So the diseases that can result from the metabolic bone disorder, it could be osteoporosis, osteomalacia androchus, osteogenesis imperfecta, Paget disease, and renal osteodystrophy. The patient usually will present with a back pain if he has an osteoporosis, or the family, they will notice a reduction in height. They will tell you that my mother, she's losing height. You ask them, how do you know that? Well, we have to alter her clothes and make it a little bit shorter, okay? Or they will have skeletal deformity in terms of kyphosis, or they will end up by having pathological fracture. And these symptoms are really warranting. The first and the highly sensitive symptom is loss of height. Always listen to the family. Listen to the family. And if they report that there is a loss of height, they are telling, well, my mother used to wear abaya size of 56. Now she's wearing 54. So the loss of height is as equivalent as the DEXA scan result to prove and diagnose the osteoporosis. There is a secondary osteoporosis. This could be secondary to drug, like use of steroid, anticonvulsant, or because of a renal disease, okay, or endocrinological problem like the parathyroid problem. Believe it or not, smoking and fatty diet can accelerate your osteoporosis. And of course, alcohol intake and immunological disease like the SLE, either directly or because of medication, and infection like the HIV and the COVID. which has been shown by latest result. This is a kind of a complicated, everybody doesn't like to read the DEXA scan, but I will help you just to know one thing that will help you to understand to do it. Just remember the magic number minus 2.5. Anything less than minus 2.5, we mean less by increasing in negativity. This indicates osteoporosis. Okay? Anything greater than zero point 0.1 is normal. Anything between minus 1 and 0.25, this is an osteopenia. So our magic number is minus 0.25. Below this, osteoporosis. Between this and minus 1, this is osteopenia. Greater than minus 1, live a happy life, this is normal. Osteomalacia and rickets, they are basically have the same pathophysiology, but it happens in different age group. If defect in mineralization happens in kids, we call it rickets. If it happens later on in life in adult, we call it osteomalacia. This could be due to vitamin deficiency, like lack of exposure to sunlight, not enough intake of dairy product that contains calcium. You have abnormal absorption for the vitamin D, or you have a renal disease that will affect the formation of the active vitamin D form, like a renal failure. Or if you don't have any of this, but you don't have the correct matching receptor for the vitamin D to act on, like in a state of a resistant, okay? Or you have abnormal level of phosphate in terms of hypophosphatemia, as I told you. The phosphate is a close friend of the calcium. Or this will end up by having a defective mineralization, and the patient will come with bowing of the legs and abnormal formation of the bones. Usually they will come with a bone pain, abnormal growth, and they will have fragility, and they are exposed to fracture, and of course they're going to have a muscle weakness. How do you treat that? It depends on the cause, but the highlight is the vitamin D, the calcium, and sun exposure. In renal osteodystrophy, what's happening? In a state of renal failure, we are losing the parenchyma. By losing the parenchyma, this will cause an abnormal handling with the minerals. The kidney, always in the healthy state, is able of excreting the phosphorus. So in a patient with a CKD, this is what I tell my student and my resident. If you see an elevation of phosphorus in the blood, this indicates a chronic kidney disease rather than acute. Why is that? Because the homeostasis at the level of the kidney is affected. So the patient would come with a high phosphatemia, and they will have a state of hypocalcemia. This will indirectly the hyperphosphatemia, if you remember from the previous slide, will stimulate the PTH secretion. And the PTH that is getting secreted, what's going to do? It's going to act on the bone, get more calcium out, get more phosphorus out, but it cannot cause the excretion of the phosphate because of the problem at the kidney level. Then, if you look at at the renal level, not only with handling with the phosphorus, also with the activation of the vitamin D. So you're gonna have a state of deficiency in vitamin D that will lead to the same problem, increase the bone resorption, okay? And you get more phosphorus and more calcium, and you will keep going on in this vicious cycle. That will result in two skeletal abnormality secondary to this phenomenon. It depends on the turnover. If you have a low turnover, you will have a dynamic bone osteomalacia, so which means defective mineralization of your bone, or you will have a state of osteitis fibrosa because of the rapid turnover of this abnormal process. Paget disease, this is the most common disease that we see in terms of abnormal bone metabolism in adult in Kuwait. So usually the patient will come to you by complaining, them telling you, I'm changing the size of my gall, it's not fitting anymore. I used to wear 54, now I'm getting 55, and it gets more and more. Why is that? Because there is abnormal bone remodeling that affect the skull, the spine, the pelvis, and the long bones. So it will cause an increase in size of the bone, okay, with warmth, and it's telling you all the time, my head is always hot. I check my temperature is normal. Okay, they will have a spinal deformity in terms of kyphosis and sometimes scoliosis, and also they will have an increased potential for a fracture. If you look at this their x-ray, they will have the commonest finding that you're gonna see the cotton wall appearance, which indicate abnormal bone formation and bone resorption. And they will have a banana fracture where the long bone will be bowing and there will be a stress fracture usually at the end. In addition to the fish vertebrae, which indicate a silent fracture in the vertebrae, and the biochemical markers that indicate the Paget disease, surprisingly, their calcium is normal, their phosphorus is normal. Why is that? It is normal because there is still remodeling going around in the bone. So there is a release of calcium and release of phosphorus, okay, by the effects of the PTH. But the abnormal thing is the elevation in the alkaline phosphatase, which indicate the rapid turnover of the cell. And if you check the urine for the hydroxyproline, you will find it elevated, which indicate the bone formation. Elevation in the alkaline phosphatase indicate bone resorption. Elevation in the urinary hydroxyproline indicates bone formation. Osteoporosis is the different thing. Osteoporosis, they will have a normal bone markers. An X-ray, the osteoporosis, you cannot diagnose it. You have to do the DEXA scan. Let me tell you them something. The way radiographically to diagnose the Paget disease is different from the osteoporosis. The gold standard for diagnosis osteoporosis is the DEXA scan. Okay, you will check the bone density at the vertebra and at the hips. Paget disease, the X-ray can diagnose it to you by having a fracture, the cotton wall appearance, which is the commonest, or you will have just like a silent fracture in the vertebrae and the other findings. So you cannot compare apple and orange. Nobody will diagnose osteoporosis from the radiographical method. Sometimes you are hearing us in the round, you are saying he's an osteopenic. Why you are saying this? Because of the bone density is faint on the x-ray. This may indicate osteoporosis, but we have to do the confirmatory test, which is the DEXA. Okay, so the x-ray, you don't use it to diagnose osteoporosis whatsoever, the DEXA scan. Osteoporosis only, not for Paget. Paget we do a skeletal survey. So we x-ray the head, the spine, and the long bones. And we look for these findings. And we combine it. Sometimes you don't find much of this finding, or it could be subtle. You have to combine it with the biochemical markers. Both of them will present with a fracture. But if the patient is very just like cautious about himself, he will give you this finding that he's changing the size of the head or the size of Egal, but not all the time. Because Paget disease of elderly, and our elderly in Kuwait, when they grow old, they will have a cognitive dysfunction as well, concomitant, because of other comorbidity. So it will be very hard to rely much on their perception and self-awareness. Well, if you look at the literature in the book, okay, the data in the epidemiology is coming from the Western country. We don't have just like a statistic about the occurrence of this disease in this part of the world, but we do see them. It's not rare. We do see them. If you don't know how do they present, you will never ever be able to identify them. But it is common. You can see them. Okay? How do you treat that? You can give a painkiller, okay? You can give a vitamin D, you can give calcium and bisphosphonate, okay, to help the bone to grow more healthier. Osteogenesis imperfecta, this is a disease of infant. So what happens? I'm just putting for you the two diagram for the bone just to try to get the difference. Basically, they are the same, only in the shaft there is much of spaces. We call this a spongy, okay, appearance of the medulla of the bone. So the patient, they can have an abnormal bone formation and bone resorption that will result in different deformities, like a broadening of the forehead, okay? This is the skeletal thing, and abnormal parallel chest, and they will have a bowing and bending of the long bones, and usually there will be a short stature. If you look at the extra skeletal manifestation, they are characterized by having the blue sclera, and some of them will have a neuronal deafness. Why is that? Because of the overgrowth of the bone will cause an obstruction on the eighth nerve, resulting in loss of hearing. And of course, they will have a poor dentation. So the mother will come to the physician and telling them, my infant is more than 14 months, but he didn't get a proper teeth yet. If you look at the teeth will be small and yellowish and decrease in size. This indicates osteogenesis imperfecta. The last slide, this we're going to talk about the involvement of the bone in malignancies. The bone can get affected by hematogenous spread from the solid organs, mainly the kidney, breast, testis, and the lung and the colon, or it could be a primary bone malignancy itself, like chondrosteoma and the rest of these. The manifestation of it that will have the patient abnormal bone remodeling in terms of formation and resorption. There are three types of bony metastasis, either osteoplastic or osteolytic or mixed. The commonest is the osteolytic, and this is very easy to identify. You will see a punch out in the bony shaft, like a hole in it. This is an osteolytic changes. Osteoplastic, this is abnormal whitening of the bone due to defective bone formation. It will be bulging, bigger, and with a different density. Sometimes you can have both the osteolytic and osteoclastic happening at the same bone. By this, I conclude my presentation, and the floor is open for any question. Welcome. Thanks. Welcome. Thank you. Allah Hafiz. Thank you. This is a revision of your chapter, basically, but I left the biomedical thing for Dr. Salwa. She will help you with that. Okay. Thank you. شوفكم على خير. مع السلامة.